Good morning. Thank you very much, Professor Zager. It is a great pleasure to be here today. I've been asked to try to analyze the results of the SHARP study, which has been presented but not published yet, in the context of risk prevention, risk reduction, and cardiovascular prevention in patients with elevated LDL cholesterol levels. Just as an introduction, I think that this audience knows very well that cardiovascular disease in patients with renal failure or any kidney disease is related to many, many different risk factors in addition to the ones that we call the classical risk factors, like LDL, blood pressure, etc. These non-traditional risk factors, many of them have been characterized already and defined at the molecular level, but many others were not. And this is the beginning of the problem, because if we look at modifying some very well characterized and known risk factors, we still leave behind those that are known yet. Many recent studies showed a very clear-cut relationship between the GFR, here at the x-axis, and the hazard ratio for cardiovascular event. And there is a direct relationship between these two parameters. But if we look at the risk factors, the list is very long. On the left side, you see the traditional risk factors. I don't have to elaborate anymore on those risk factors which are well known. On the right side, you will see a list of non-traditional risk factors. Some of them are also very well known, like anemia, volume, overload, etc., etc. But on the bottom right, you can see those that were more recently characterized, like the role of lipoprotein A in the ApoA isoforms in the risk of cardiovascular disease in renal failure patients. More recently, we started to understand the importance of remnants, of lipoprotein remnants in the risk of those patients. Homocysteine is important, malnutrition is important, other thrombogenic factors are important, and many, many others which have not yet been characterized. But if we look at the practical terms and we go back to guidelines, the guidelines of those that are interested in kidney disorders, the nephrologist, issued very similar guidelines to the cardiologist. And the target levels of LDL are very similar, although a bit higher than we know from the cardiological groups. But again, they look at the LDL as a major parameter. Now, the SHARP study was the largest study in renal failure patients that has been presented very recently, but not yet published. And this is a major problem, the first problem, because when we look at the study that has not been published, all the different parameters that we are interested in, for example, in diabetic patients, the subgroups, in post-hoc analysis, etc., cannot be analyzed at this stage. If we look at the eligibility and the inclusion criteria of this study, this is a real unusual study. First, it is a study that has been devoted to patients with renal failure. 2/3 of the patients that entered the study were not on dialysis but had kidney disease. A third were patients on dialysis. In order to enter the study, you already had to have a high creatinine level as shown here, the age above 40 because this is a higher risk, and no history of myocardial infarction. The design of the study was also a little bit unusual. Almost 10,000 patients were randomized. But the first question that was asked by the investigators, and it was analyzed after 1 year of the study, was a safety question. Is the combination between simvastatin 20 milligrams and ezetimibe safe as simvastatin alone or as placebo? And this analysis was done and allowed to run the study for additional 4 years by re-randomization of those patients that were on simvastatin into 2 major groups. So one group is the placebo group on the right, and the other group is the ezetimibe simvastatin group on the left, almost 5,000 patients in each group. But if one looks at the baseline characteristics, we recognize our patients, our high-risk patients. Because the age is 62, the mean age is 62, a little bit high blood pressure, body mass index is 27, which is very similar to other cardiovascular studies, 30% smokers, a little bit lower than we are used to, and diabetes, almost a quarter of the patients, which is very usual in this type of studies. The eGFR was 27 for those patients that were not on dialysis. Now, how do we look at renal failure? We look at renal failure patients as characterized by the GFR. On the left side, you see stage 1, those patients that are always normal. On the right side, stage 5, you see those patients that have kidney failure and are on dialysis. Some of them continue to transplantation. I did put the sharp patients on the bottom here, the bar, and you can see that 36% of the sharp patients were those that had a stage 3 renal failure, and 43% of the sharp patients had stage 4. 20% of the total patients had kidney failure. And here there is something additional unusual about the SHARP study. The SHARP study baseline results were published a few weeks before the study was presented. Usually a baseline paper is published many years before, several years before the final results are published, but here the investigators, and this is the Oxford group, decided to publish it very closely to the release of the results. And here they show the 1-year LDL reduction of 30 milligrams with simvastatin and 43 milligrams with the combination of simvastatin and ezetimibe, and the confirmation of safety. But there is an additional thing that was done, which is also unusual for clinical endpoint studies. The steering committee decided to change the primary endpoint just a few weeks before the result of the release of the results. And we believe, I personally believe, that they didn't know the results beforehand, but they did it because they were afraid of one issue, which is the hemorrhagic stroke, as I will show you in a minute. So we have 2 key outcomes. One is the major atherosclerotic event outcome, which is coronary death, myocardial infarction, non-hemorrhagic stroke, or any revascularization, which is the new primary endpoint. And here we have the old primary endpoint, which is major vascular events, cardiac death, myocardial infarction, any stroke, or any revascularization. And there is a big difference between these 2 outcomes, because, especially for renal patients, because cardiac death in renal patients, as we know, is not always caused by coronary artery disease, but sometimes yes, or many times yes. And stroke, hemorrhagic stroke, may be a special problem in renal failure patients, especially because of the issue of anticoagulation, etc. But luckily, what happened in the SHARP study, if we look at the major arteriosclerotic events, we can see that the study was positive. So we had a positive outcome, and everybody was really happy. And this was even statistically significant. A few weeks after the SHARP study was presented, the Lancet published a new meta-analysis, the CTT, Cholesterol Treatment Trials Collaboration meta-analysis. Now, in addition to the 90,000 patients that were published before, now we have a total of 170,000 patients and 26 randomized clinical trials of LDL lowering, and we can look carefully on the SHARP results as extrapolated on the CTT meta-analysis. Okay, so in the SHARP we have 32 milligrams at the average reduction of LDL, and if we look at the figure that you have here, that includes 21 statin versus control trials and 5 more or less meaning high statin, low statin dose, or different statins with different efficacy, you can see that SHARP as a primary endpoint lies very well on the figure. Now, the steering committee was afraid, as I said, on the difference between the two different primary endpoints, but this was not really a major problem, as you will see now. If we look at the major arteriosclerotic events, there was a reduction of 16.5%, and if we look at the other primary endpoint, which is the major vascular event, there was a 15.3, almost the same reduction in cardiovascular events, and the same, almost the same p-value, and I think that everybody can rest assured that this is okay. Going back to the CTT meta-analysis, which was recently published, as I mentioned, now it is very easy to look at the effect of a 1 millimole reduction of LDL. So 1 millimole is 38 milligrams of LDL. If you reduce 38 milligrams of LDL in your patient, you can expect to reduce the cardiovascular risk of 22%, and here we are looking at the major vascular events. On the left, bottom left panel of this slide, I tried to extrapolate the SHARP results, and in the SHARP, there was a reduction of 32 milligrams of LDL. We can estimate that if the reduction was 1 millimole, we could expect almost a 20% reduction of major vascular events, which is very similar. If we look at all-cause mortality, now in the SHARP study, there was no reduction in all-cause mortality. But one can ask the question, could we expect a reduction in all-cause mortality in patients with renal failure in that sample size? And probably the answer is no. But if we look at the meta-analysis, at the CTT meta-analysis, and we look at all-cause mortality, on the left bottom side of the slide, you can see any death, and the reduction of any death is 10%. So this is the rule of thumb that we have now. As we know, during the last 3 to 5 years, there were several important questions related to cancer. And here I think the Oxford group did a nice job, because they looked at cancer incidence and also the different kinds of cancer, different types of cancer, and there was no difference between the ezetimibe-simvastatin combination and the placebo. If we look at the site-specific cancer, from the CTT meta-analysis, we have a very nice number. So the number shows that in that meta-analysis of 170,000 patients that participated in those studies, there is no risk of cancer. There is no reduction of cancer, of course, but there is no risk of cancer. I think this lays to rest the whole big question about cancer and statins, and cancer and lipid lowering, and cancer and LDL. Another important question regarding safety is, of course, myopathy. And as anybody can realize, these patients with renal failure have a major problem of myopathy, especially if you increase the dose of a statin. And that's why the nephrologists usually use a low dose of statin in these patients. But here the combination of ezetimibe-simvastatin was not different than placebo in terms of myopathy and the other risk factors. Again comes the question, what can we learn from the SHARP results, and what are the implications on our high-risk patients? And here I want to take you back to the TNT study. Now, the TNT study is a pivotal study. It is the first major study that included 10,000 patients and looked at atorvastatin 80 milligram versus 10 milligram in patients high risk of myocardial infarction or in patients who were on stable coronary disease. I personally participated in the safety monitoring board of that study, and it was really exciting to see the results. But here I will show you one of the post-hoc analysis of the TNT that I think is intriguing, because the TNT study was not done on renal failure patients. But if you look back and you analyze the results, you see that there were quite a lot of renal failure patients, and you can look at the difference of impact, first of renal failure on the risk, but also on LDL reduction using atorvastatin 80 milligram as compared to the 10 milligram in those patients with renal failure here in orange as compared to those without renal failure here in white. So what can we learn from here? is that those patients that have renal failure, of course, they have higher risk. Because they have higher risk, it is interesting to see what is the impact of LDL lowering. It is interesting to see what the atorvastatin 80 milligram dose is doing. But it is also interesting to look at the NNT, the number needed to treat. So the number needed to treat in those renal failure patients is 24 in order to prevent one cardiovascular event, as compared to the number needed to treat of 74 in those patients, the other patients that did not have renal failure. Two other studies that are worth mentioning here in the context of renal failure are the 4D study and the AURORA study. Now, the 4D study is a specific study done on patients with hemodialysis. And these are the most difficult renal patients that we have, patients on hemodialysis. This was a very simple protocol, atorvastatin 20 milligram versus placebo, and I think that it was legitimate to use placebo on those times, mainly because we didn't know if there is an impact of statin in the patient on hemodialysis. Just to remind you, in the SHARP study, a third of the patients were on hemodialysis, and there was no impact of LDL lowering in those specific patients as far as we know now from the presentation of SHARP. We don't have the final results yet published, as I mentioned before. But the 4D study showed clearly that atorvastatin 20 milligram versus placebo has nothing to do with prevention of cardiovascular disease in patients. These are mainly German patients, but it is a nice, well-done study. Another one that was done also in renal failure patients on hemodialysis is the AURORA study, also a classical study, very well kept. Patients were on the study for 5 years. Rosuvastatin versus placebo, nothing happened. Meaning that what we can learn from here is that patients, when they are high-risk patients, not yet on dialysis, they benefit from LDL lowering. Once they are on dialysis, they do not benefit from LDL lowering, at least not for 5 years, but maybe we will learn in the future that if you keep this treatment for many, many years, and this will elicit many different discussions, and maybe we do something good for these patients. But as far as we know now, no method of LDL lowering in the short term of 5 years has any implication on cardiovascular disease in patients on dialysis. I will ask you a question in 1 minute, and we'll see what you think about it. So just to conclude, the risk of cardiovascular events is very high. In patients with renal failure, many of our patients have renal failure, at least mild renal failure or moderate renal failure. Meta-analysis showed the benefit, and I don't think we have to do more meta-analysis. 170,000 patients in prospective meta-analysis of the CTT is probably good enough for the next 10 years. Now, the problem is here for patients on dialysis. Maybe they have a different risk or other risk that determines the future of these patients. And I think that we can say clearly today that LDL lowering, no matter how we do it, and I think that is well accepted around the world, is very beneficial for patients who are at high risk, have renal failure, but not yet on dialysis.